Oceanside TV, we're here with Dr. Deeptha Sastry, and she is a urogynecologist, and she has been so helpful to the Seacoast area for all women. Thank God she's in the area. No, it really was not good before you came here. So I think the question I hear most when I recommend your services is, what in the heck is that and what does she do? And so you are a urogynecologist, so why don't you just explain first what your specialty is and kind of how, what your path was to get there.
So urogynecology is a combination of urology and gynecology. It goes through either OBGYN, like I did for 4 years, and then a 3-year fellowship for the specialty. It's a pretty young specialty, maybe 1996 was the first fellowship, only about 50 of us a year when I graduated. I tell patients, we're a combination of bladder down, which is what Urogyne does, and for urology they do bladder up. So we have some crossover on the bladder, but I will take care of all things bladder related, pelvic floor related. The other name for us is female pelvic medicine and reconstructive surgery. So
which is why we know each other so well.
So the pelvic medicine piece of it, incontinence, recurrent urinary tract infections, pelvic pain, all of those things where we have a lot of overlap.
Yes.
The surgical part could be prolapse, incontinence, sometimes pelvic pain as well. So it really encompasses all things pelvic floor. We do bowel issues, bladder issues, sexual issues.
Yeah. Why do you think it's such an unknown specialty, and why is it still the Wild West out there for women?
I think women tend to not want to talk about these things. So if I have a patient come in and maybe they're not talking to their friends about what their issues are, and the average time for a patient to come in about a pelvic floor disorder is anywhere from 5 to 10 years. So they've been dealing with these issues for so long, and they're embarrassed to tell their primary care, or their primary care is
or they've mentioned it.
They're overloaded with
and
so
it's
many
been overlooked.
other things.
Yeah.
And they mention incontinence, and they have 10 other medical problems, so that kind of gets swept under the rug.
I think there's a kind of a culture out there too that's normal as a woman, especially post-baby, that it's just suck it up, and that's kind of part of the experience.
So what we were always taught was, after you are potty trained, leaking is not normal. Incontinence is not normal. Whether it is manageable is one thing, but most women have been affected in their quality of life, and that's why I chose this profession, is because you can really change quality of life for women on a day-to-day basis.
Yeah, I would say that I'm in that same boat. Yeah, it's pretty powerful. It feels nice when you can help somebody, and it's pretty profound too. So what do you think is the evolution that's going to happen for women? Where do you see that? Because I feel like the tide's changing for women.
More women are talking about it. So there are more resources out there. You know, 10 years ago when I started here, so many women that I saw had never heard of pelvic floor muscle dysfunction, high tone. They always were told, oh, we need to Kegel for everything. Yeah. If they were having pain with intercourse, they would say, oh, you're not having intercourse enough. So lots of different myths behind it. And
women really like being told that.
Yeah. Do it more, it hurts.
That's really a special piece of advice.
So many women going through that, where now you pick up a magazine and you can find that somebody is talking about high tone, that you can over Kegel, or that isn't exactly the piece. Not everywhere right now, but it's definitely in
our bubble. I feel like at least it feels like it's changing. So if a woman had some sort of symptom, when would they seek out you? When would they seek out their primary gynecologist, urologist?
Most of the time, what I tell, even if I'm talking to primary care physicians, if I'm doing a talk for them, I will say, if you have a patient who is complaining of urinary incontinence or frequency or urgency, they can not have to do any of the workup. They come right to me. Those type of things are kind of direct to urogynecology. The urologists absolutely do that as well. The difference is that if there is a prolapse piece contributing or pelvic floor muscle spasm, so the pelvic floor, for us, we pay much more attention to that. So that piece of it is really integral into everything that we do. So that's kind of where they would come into our practice. Oftentimes we get referrals from general gynecologists. Again, most general gynecologists don't do incontinence, so patients would come here. Or if they've gone to a general gynecologist for pelvic pain and they've ruled out all things that are actual physical etiologies, things that they can see on imaging, or fibroids, endometriosis, when it's outside of the box of they're still having pain even though they took the ovarian cyst out. What else is going on? Or maybe somebody has told them they need surgery and they're not really convinced and they're having pain. Those are the patients that they benefit from at least getting an evaluation and saying, is that the right path or is that not?
Yeah, okay. Now, I have found that when working together, you are one of the, I wouldn't say few, but you definitely highly prioritize physical therapy. I always tell patients that you want to do surgery on people who really need surgery and really will have better outcomes. How did you get to incorporate physical therapy so much in your practice?
So when I trained in between Philadelphia and New Jersey at Cooper, and there was a physical therapist in our office all the time. One of the pieces that we know is that if you either have spasm or weakness, if you do PT before surgery, so I will tell patients the worst case scenario is that you are completely optimized for surgery, and then we operate, and you're doing great. The best case scenario is that you go to PT and you realize that maybe you don't even need surgery, and then we don't have to proceed. So there's no downside, and there's a lot of upside. A
lot of upside. Of course, my bias, why wouldn't that be how things work with every surgery? I think, and you probably see this, that if somebody goes into surgery and their nervous system is completely elevated and there's high tone and stress, I mean, how is that person going to have a better outcome? It could be fine still, but...
Yeah, I very much push people to PT, especially if they have high tone. Whatever our next step is, I feel that they're not going to benefit from that next step if they don't deal with their high tone.
Yeah.
So those are patients absolutely, I kind of say, you have to do this for us to move to the next level.
And it's been greatly appreciated. So where do you see your practice evolving and female medicine?
What I would like to see is women talking about it more and just being more open to saying to their primary care, listen, this is bothering me. I need to know where to go. Or understanding that urogynes exist, that we are out there, that if you're having a pelvic floor disorder, if there is, and that includes anything that is going on with your bladder, your bowels, your sexual function, all of those things are encompassed. They just kind of automatically think, oh, I know who to go to at least get started. This is who deals with that. Because I have patients who aren't sure. They go to a gynecologist or they go to a urologist, and that mixture in between, well, I have prolapse and I have incontinence, or I'm having pelvic pain and I think this is prolapse.
Yeah, I think it's hard too, because even in the medical world of providers who deal with that exclusively, I think there's a lot of variation. Mm-hmm. And I unfortunately, I think that's where women's medicine, it's maybe we're in the 50s now, like we're evolving, but it just, women still aren't studied very well and included in research studies. So I think that it's coming, but there's a lot of variability. And I always tell people to get several opinions and, go see a couple different providers, because then you're going to have a comprehensive view. And I think education is power. So one thing we were talking about is you don't have to come see a provider when you're absolutely sure you need surgery or there's no other option. Yeah. Come for information. Come to make your decision. So I think I would love to see choice be a big part of how patients use us in the future. So is there any, what's your waiting list these days? Is it under a year?
We're working on it. Usually about 3 months, but what I tell patients is if you are flexible, they'll give you something 3 months from now, but most of the time, people's schedules change. So if I have a cancellation, we absolutely put things in. I often add an extra day here and there just to kind of get people moving. So, we catch up a little bit.
Yeah.
I also have a nurse practitioner that I have been working with for the past, I would say, 7-8 years.
And she's great.
She is fantastic. So I talk to her about every patient. So it really is, if patients see her first, I'm still talking to her about them. I know what's going on. So then when they see me, she'll get them started. Yeah. And then I will see them. And so we're trying to move the process along a little bit quicker to see patients quicker.
Yeah, I think it's nice working together, because I often know when to send somebody to you. I mean, that collaboration is really helpful. It makes the whole process more efficient. Yeah. Well, thanks so much.
Thank you.
And I hope that this helps bridge the gap and people know what a urogynecologist is now. Thanks so much for watching that video. Please hit the subscribe button if you'd like to see more of those videos and keep learning on how to read your body.